It's like you know how to use Zoom until all of a sudden you're on like a different computer setup, and then you're like, I have no freaking clue what's going on. All right, so we'll deal. Thank you guys. So, just FYI, if you hear a voice from beyond, it is my friend and mentor, Peter Sato, who is here in the audience from Mass General, who's a head and neck pathologist there as well, and the director of the head and neck, and I don't know, is your endocrine together or separate? Together. So yeah, so if he pipes up, please, listen to him. All right, so salivary gland pathology. It's really not that old, I promise. Hold on. Okay, where are we? All right, so we're gonna sort of go over salivary gland histology, non-neoplastic entities, benign and malignant neoplasms. Most of the salivary things we deal with from I assume, mostly radiologic, but certainly mostly surgical perspective are the neoplasms of salivary glands. So we're going to focus a lot on the salivary tumors, but we'll go over the other things as well. As a reminder, the types of glands are the parotid, the submandibular, and the sublingual. And so you can sort of, as a pathologist, we can determine where the gland is based on the components that are present on the slide, whether they be serous, seromucinous, or mucinous. In the upper aerodigestive tract, lung, trachea, etc., you have multiple minor salivary glands that don't really have, large volumes or named, but they sort of exist. And so you can get salivary type lesions all the way through those. So looking at the three major glands, the parotid, the submandibular, and the sublingual, you can see that the parotid is mostly these purple serous acinar cells that contain the zymogen granules that are the predigestive enzymes. You can see that the sublingual, as well as some of your minor glands like those on the palate, are entirely mucinous with this whitish material. And then the submandibular is mixed. So you have these sort of demilunes of the serous and the rest are mucinous. So just, based on where you are, the functionality is different. We've got mostly digestion, mostly lubrication, and then sort of a mixture of both. So one of the things that we do see quite frequently that's not a neoplastic condition is biopsies to evaluate, excuse me, for Sjogren syndrome. So when a patient has atypical serology or atypical clinical presentation, excuse me, the clinicians occasionally biopsy the minor salivary glands of the lip such that they ask us to identify inflammation. And so the grading system that was devised, in concert with the clinical symptomatology is supposed to show that any focus of 50 or more lymphocytes is supposed to be predictive of a potential Sjogren's disease. And so we grade these as the most inflamed 10x objective, where we see these foci of lymphocytes. Now, mostly it's like either nothing or very minimal inflammation, because these patients that they biopsy aren't the patients with full-fledged obvious disease. These are the patients, right, that, they don't know if they have Sjogren's. So generally the pathology is equally as confusing. Is it inflamed? Is it not? Is it focus score? Is it not? But that's sort of one of the major non-neoplastic things that we see. So if you ever see focus score, et cetera, that's where this is coming from. Other non-neoplastic entities we see in the salivary gland include atrophic changes, generally due to things like previous injury, or in this patient population, chemoradiation, generally for prior head and neck cancer, right? So when your salivary glands are included in that field, they get blasted. And so what happens is they essentially undergo fatty replacement, they undergo fibrosis, they undergo shrinking of the sort of acinar structures, but with this ductal lobular architecture maintained, right? So you can see this nice, oh, you can't see it over here, but you see this nice duct in the middle with these acinar structures around it. For you guys over here, duct in the middle, acinar structures around it. And the most severe outcome of these atrophic and injurious changes and ischemic changes is so-called sialometaplasia, which is squamous metaplasia of salivary units. So from the normal ductular and acinar salivary structures, you end up undergoing a transition to a squamous type of epithelium, mostly because it's sort of hardier and more resistant to trauma. We still see some retention of the mucinous glands in the here, which make us know that this is indeed salivary tissue, not true squamous tissue. But this is sometimes what it looks like as these ulcerative lesions on the palate, usually post-radiation or some kind of other ischemic injury. So this can be a challenge to pathologists because it can mimic squamous cell carcinoma, but if you see sialometaplasia in a report, that is essentially what it means. Okay. So now we're going to move into any other benign or non-neoplastic, well, we'll talk about the benign neoplasms, but any other non-neoplastic salivary issues that you have questions on. These are the things we see mostly histologically, but okay. All right, so tumors. So as we know in the salivary gland, benign tumors are much more frequent than malignant tumors. Mostly we're dealing with tumors in the parotid, but certainly all of the other glands pop up as well. The site with the highest rate of malignancy, interestingly, is the sublingual gland. And just in general, salivary gland carcinomas are a very small percentage of head and neck cancers, about 6%. We certainly know that the most common tumor overall is pleomorphic adenoma. The next most common benign tumor is Warthin, and the most common malignant, just statistically, is mucoep, followed by adenoid cystic. So this is what we're going to see most often, but we'll go through a good number of them. Okay. So sort of most important for diagnosis, most patients with a salivary gland suspected neoplasm will undergo usually an FNA biopsy, but sometimes a core. And so what's important for us to tell, the treating team is this truly a primary salivary type tumor in a salivary gland site, or is this a metastasis to a salivary site / an intraglandular node, right? So if you think about it, the parotid, the submandibular, sublingual, all contain, nodes in and around their parenchyma. And so you can get metastases to those areas as well, generally from cutaneous sources, melanomas, squamous cell carcinomas, or even direct extension sort of through the buccal mucosa right out into the parotid region. So is it primary? Is a metastasis? If it's primary, is it low versus high grade? Generally, this is the most important feature we can tell on biopsy, because either if it's benign or low-grade malignant, the primary treatment is surgical resection with negative margins. If it's high-grade malignant, generally they'll add on a neck dissection to make sure that there are not any occult mets on that ipsilateral side. So the surgical treatment varies between those, so we really try to give some indication of whether it falls into one of these two groups, histologically low or high grade. Biopsy can be extremely challenging for salivary gland because the histologic features and the cytologic features can be extremely overlapping. And so sometimes if you see us hedging, low-grade salivary neoplasm or high-grade carcinoma, that's sort of a, hey, we're telling you what you need to know to operate on the patient, but we'll give you the final diagnosis after resection where we can better make an evaluation of the actual histology, if that makes sense. So yeah, once the patient comes to resection, again, we'll confirm whether it's a primary versus a metastasis, confirm the histologic type and the grade, talk about the margins, and if it's a malignancy, of course, the remaining sort of staging. Does that all make sense? Cool. So when we, yes, go.
The important thing radiologically too will be for them is about, is the lesion well circumscribed? Does it have clear edges around it? The other thing that radiologically is going to be important, and the same thing, part of it too, of course, you always need to think about the is the clinical picture. What's the clinical history? Does the patient present with pain, or does the patient present with a painless mass? If the patient presents with pain, it's much more likely to be malignant. And the question ends up being radiologically too, does this tumor involve the facial nerve? Because one of the issues that Nicole's mentioned in terms of either doing a primary resection, a simple resection for a low grade or benign tumor versus a high grade tumor, may be sacrifice of the facial nerve, which would be, obviously it's devastating for the patient. And if the patient has a benign tumor, is much more likely to be able to, the surgeon will leave a bit of residual tumor in situ rather than cut the facial nerve. But if the biopsy is suggestive of a high grade malignancy, then the primary surgery may involve a resection of the facial nerve. So radiologically, it's superbly important for you to recognize the presence or absence of the facial nerve involving the tumor, so that this actually helps the pathologist as well when they're going to try to make this decision about if they're going to hedge and what direction they may want to do that in terms of what, what's going to happen with the patient, because the patient may lose the nerve. So that's I just kind of wanted to add it in because I thought that'd be helpful.
Yeah, no, thank you so much. That is helpful. See, peanut gallery, here we go. Awesome. No, that's very, very good. Questions? Cool. All right. So we're going to sort of talk about first the benign tumors and whether or not they have malignant counterparts. And then we'll talk about the tumors that are sort of purely malignant with no benign counterpart. And so, when we see a tumor that is potentially one of these benign things on the left, like always, always the question is, could it be worse, right? And so when you're seeing something on a core biopsy, you may not necessarily have the information for the periphery of the tumor. And in salivary gland tumors, one of the most important items for diagnosis of malignancy is peripheral infiltration of either the lesion's sort of, quote unquote capsule or infiltration into the adjacent parenchyma. And so without that information, one may not be able to distinguish between a benign oncocytoma, for example, and a low-grade oncocytic carcinoma, for example. Same with the basal cell neoplasms, right? So just things to keep in mind for when we're looking at these histologically. You may, in the historic literature, read such a term as quote unquote monomorphic adenoma. That is in contrast to the so-called pleomorphic adenoma that we will see. It is very histologically heterogeneous, hence the term pleomorphic, whereas these on the bottom are somewhat more monotonous, hence monomorphic. When I look at salivary gland tumors, one of the first things that's helpful to me is to determine the number of cell types present. And generally the cell types in the salivary tumors recapitulate in some regards the ductal elements, whether they be the epithelial, the sort of central cells, or the myoepithelial, the contractile cells at the edges, right, that sort of pump the luminal contents out into the secretory system. So I like to determine whether one or both of those elements are present, and that helps a lot with diagnosis. Genetics, I may not have them all listed here, but genetics are becoming important as well in diagnosis of salivary gland neoplasms because many of them either have some specific point mutation or gene rearrangement. So starting with pleomorphic adenoma, as mentioned, circumscription is important both radiographically as well as grossly and histologically, right? And so here we have a very generally well circumscribed lesion, but with a somewhat heterogeneous cut surface, meaning there's some sort of yellowish areas, there's some whitish areas. And in the picture on the bottom left, pleomorphic adenomas can grossly resemble cartilage because many times their stroma is actually truly chondroid. So that can be a helpful gross indicator of a PA. As I said, it's polymorphous or heterogeneous in terms of its morphology and architecture. It's not so-called pleomorphic in terms of its nuclear or cytologic atypia. So sometimes when you say, oh, this tumor is really pleomorphic, that means it's wild. Nuclei are of all various shapes and sizes. That's not necessarily the case here in pleomorphic adenoma, but it is more of a pleomorphism of the architecture and the stroma. So diagnostic features include these bilayered ducts with epithelial, as you can see here, surrounded by a smaller compressed rim of myoepithelial cells. Actually, this is a really nice duct right there showing both components, and then this chondroid or mixochondroid stroma. But the myoepithelial component of these tumors can be quite variable. And so you may see sheets of spindle cells, sheets of plasmacytoid or small compressed cells. These are generally the so-called myoepithelial cell population that has expanded and can, in some cases, overtake a large percentage of the tumor. Again, the stroma can be myxoid or chondromyxoid. Sometimes we see these tyrosine crystals. That's fun. I know, Dr. Ganat was looking a while ago at trying to identify PAs with tyrosine crystals to see if, maybe you guys could see those radiographically, but we don't report them. So it's really hard to be able to identify which PAs actually have tyrosine crystals. I don't know if he's still interested in that project. It may have just dropped. But things PAs can do are recur after incomplete excision, metastasize theoretically as this so-called benign metastasizing PA, but I don't know if that's really believed out in the world, where the pleomorphic adenoma maintains its low-grade looking morphology, but travels somewhere down in the neck that's outside of the original surgical site. Peter, do you believe in this? Or is this wrong?
I mean, well, they look benign, but when they show up in the thigh, they look exactly the same as they do the original location. So
Right.
that's where it's a benign metastasizing, but at that point, obviously, it's overtly malignant.
Right.
So
Behaviorally.
yeah.
Exactly. So benign appearing. And then the worst thing it can do is transform to a high grade carcinoma, so-called carcinoma XPA, meaning carcinoma arising in a pleomorphic adenoma. So this is what those things look like. So this is just recurrence, where you have these multiple small nodules that sort of percolate through the fibroadipose tissue in the region of the prior excision. And then carcinoma X looks like either it starts as a proliferation of the epithelial cells within the ducts. Being now we actually get pleomorphism, we get nuclear atypia with prominent nucleoli, mitoses. Then this component ends up essentially invading and breaking out of the original boundaries of the tumor and invading into the adjacent stroma. And so here is your pre-existing, benign pleomorphic adenoma component that is this sort of vague nodule, and then bam, you have these sort of tongues of invasive carcinoma. So this is carcinoma X pleomorphic adenoma. Generally, these tend to be, once they're out, they're bad, they're high grade. And they can be of various morphologies. They often end up being of a salivary duct carcinoma-like morphology, and we'll talk about salivary duct in a bit. So, okay, moving on. All right, so the genetics of PA are usually PLAG1 or HMGA2 genes with various partners, so that can be helpful in diagnosis if needed. There theoretically can be tumors of purely myoepithelial cells that lack the ductal or epithelial component of a pleomorphic adenoma that would be regarded as myoepitheliomas. I don't know, I think these are very rare and may be just duct poor pleomorphic adenomas, but essentially they can take on the morphology of any of the myoepithelial cell morphologies that we sort of saw in the other slide. Additionally, you can get myoepithelial carcinomas that can either be derived from a pleomorphic adenoma or de novo. And these may have somewhat different genetics, namely EWSR gene rearrangements. So these are the appearance with these cords of myoepithelial cells in the stroma, these sort of lobulated architecture and an invasive destructive growth pattern. Wharton tumor, you'll probably see a lot in radiology because these pop up pretty much very frequently in patients who are undergoing PET scans for some other reason, colon cancer, lung cancer, whatever, right? Boop, something pops up in their unilateral or bilateral parotid. Is it well circumscribed? Is it cystic? Does it look like it may have some grungy cystic material in it? These are probably a Wharton tumor. And so they often undergo FNA biopsy just to confirm the diagnosis, and sometimes undergo subsequent resection, but not always, right? So think about it. These people are smokers. They're having, again, they're developing other kind of cancers. They get a PET scan, they get found. So that's often how Wharton tumors come up. But they are defined by two things. One is the prominent background lymphoid stroma, seen here with very blue, and the other are these eosinophilic or oncocytic epithelium that is bilayered and creating these large cysts or ducts. And so you can see the oncocytic cells have these large round nuclei, abundant pink cytoplasm. And this abundant pink cytoplasm is due to the fact that these cells are rich in mitochondria. They're very energetically, active. And so, I wonder whether it's this mitochondrial predominance as well as the background lymphoid stroma that perhaps make these very PET avid, right? So the mitochondria will uptake the glucose, the lymphoid stroma, if it's active, may uptake the glucose and hence account for the uptake on PET. That's my theory. But histologically, that is a characteristic feature of a Wharton tumor. Comments, questions? You guys probably see these quite a bit. All right, so the other oncocytic lesion that we see that's not a Wharton tumor, because it basically lacks the lymphoid stroma and it's much more solid, is an oncocytoma. And so these generally tend to happen in elderly patients who tend to have oncocytic metaplasia of their salivary tissue for kind of, aging reasons, I suppose. And so you get little metaplastic changes of your salivary epithelium to little nodules or clusters of oncocytes. And then they sometimes grow and they develop into these larger tumor-like lesions or oncocytomas. So as you can see here, the cells are very similar with this abundant pink cytoplasm, large nuclei, prominent nucleoli, but really no lymphoid stroma and no cysts or duct-like structures, just solid nesting cords. This is that background, like I was saying, of this sort of nodular oncocytosis or oncocytic metaplasia, where you have a little nodule here, a little cluster here, maybe a larger one here and an even larger one here. And then one of these just keeps growing and growing and growing and becomes an actually like identifiable different tumor. Okay, so that's generally the background. But just like with most of these, you can get a so-called oncocytic carcinoma that is defined essentially by an infiltrative growth pattern. So you can see here, one edge is circumscribed and the other has these tongues of invasion. Oncocytic carcinoma, as with any salivary carcinoma, can be either histologically low or histologically high grade with necrosis, mitosis, et cetera. There is potentially some controversy as to whether oncocytic carcinomas by themselves exist or whether they are just variants of salivary duct carcinoma. When I show you salivary duct, you'll maybe see the similarities. But for now, we're going to assume that oncocytic carcinoma may potentially be its own diagnosis. Okay. Next is the basal cell neoplasms. So this is similar in terms of you have a benign and a malignant component, a basal cell adenoma and a basal cell adenocarcinoma. Now, keep in mind that this is not basal cell carcinoma like of the skin, right? Basal cell carcinoma of the skin is basal to us as pathologists just means it looks very blue and primitive, and it doesn't have a lot of cytoplasm, so it doesn't really look very pink on histology. It looks very blue and so-called basaloid. So basal cell neoplasms of salivary and basal cell carcinomas of skin all do look very blue, but they arise differently, right? The skin arises from the basal, derived tissues of the epidermis, and basal cell adenomas and basal cell adenocarcinomas are of the glandular cells of the salivary. And so how they look are as such. Again, the benign tumors are circumscribed or encapsulated, but look very blue on low power. And you can see that they have these nests with peripheral so-called palisading, meaning the nuclei line up like a picket fence, meaning you have these central cords of cells with this occasional eosinophilic hyalinized sort of stromal ball-like material. This is probably basement membrane-like material that's secreted by the cells. So basal cell adenocarcinoma, again, is essentially defined by its infiltrative growth pattern. And interestingly, basal cell adenocarcinomas of salivary gland can have the same genetics as these familial dermal cylindromas, the CYLD gene. So you can see loss of heterozygosity of this gene in both these patients with the so-called turban tumors, as well as basal cell adenocarcinomas of salivary gland, cylindroma gene. So here, again, you have these sort of jigsaw puzzle-like appearance of blue cells, but with nests that sort of percolate in between the normal salivary parenchyma. But on high power, the appearance is quite similar with this peripheral palisading and basement membrane-like material. So over here, peripheral palisading, basement membrane-like material. Generally, these are low histologic grade, but as usual in our pathology reports, we try to provide your synoptic of a histologic evidence of either a low or a high grade. When we talk about mucoep, we'll talk about this quote unquote intermediate grade category. And I know that it's not a category that is very helpful for treatment, because should you treat it like a low or should you treat it like a high? But so we really try. We try to push into a high or low, but sometimes it's challenging. Okay, I know I'm going kind of fast, but it's a long topic. And okay, questions, comments, peanut gallery. Yes. Yes. Yeah. There is. So onco cancer actually originally derives from the Greek word for swollen. So cancer, right, or a tumor is a sort of a swelling, and these cells are sort of tumorous or swollen with the mitochondria. So it's the common derivative of the word. Exactly. It has nothing to do with cancer. Yep. It has everything to do with the swelling of the cells. Exactly. They're swollen with mitochondria. Exactly. All right. Cool. So the next benign tumor is canalicular adenoma. And so these are very characteristically present on the upper lip of sort of middle-aged to elderly females. Not uniformly, but very characteristically, clinically is where these things will be found. They are these sort of bilayered strands of epithelium with this sort of background myxoid to vascular stroma. These are pretty rare, but just mentioning them so that you know that they're out there. All right, moving into the tumors that essentially only have malignant counterparts and do not have a benign counterpart. So if we see anything that fits one of these diagnostic patterns, it's automatically malignant. Then it's just a matter of determining the histologic grade. And so I believe that some of the genetics, I have not updated all of the genetics. If you're interested, I can give you the updated list of genes here, but most of these tumors now have some genetic defining mutation or translocation. I apologize that it's incomplete. But the same with the benign tumors. I again like to determine whether there are multiple or single cell types. And again, that will help me put the tumors into one of these multiple categories, and then we'll use some morphology and immunostains and potentially genetics to sort them beyond that. So we'll start with mucoep. We know this being the most common salivary carcinoma, and in fact can occur also in children. So don't think that kids can't get carcinomas, because they certainly can, and they can get mucoeps. These can occur in both the major and the minor glands, and in fact, mucoeps we can also see in the lung, the thyroid. It can be seen in many places. This is one of the few salivary types of tumors that is thought to have a sort of potentially 3 cell types, which I'll show you on the next slides, a squamoid, an intermediate, and a mucinous, and generally have CRTC1 or 3 and MAML2 translocations, which are diagnostic. And so on low power, mucoep can be either solid or sort of micro and macrocystic, but in all cases, one should see in cells that have intracytoplasmic mucin, as you can see here with this cytoplasmic pallor, should see cells that are almost look like squamous, so-called squamoid or epithelioid, and then these so-called intermediate cells, which often are the predominant cell type, that are sort of nondescript, bland appearing monotonous cells. So these are the 3 cell types we look for in mucoep. Sometimes, more interesting for pathologists perhaps, but sometimes cytoplasmic clearing in the form of glycogen can mimic mucin. And so we have a technique to determine whether the cytoplasmic content is mucin or glycogen, and it's a PAS with diastase or amylase stain. So the amylase or diastase will digest out the glycogen and it will appear clear in the cells, but it will not digest out the mucin. So you will retain that, that staining characteristic. So this can help us between something that's truly a mucinous cell and something that's not. If it's not a mucinous cell, then it really shouldn't be regarded as a mucoep. We talked here about, we talked before about the low intermediate, sorry, I don't have the right slide here, but there are many grading systems for mucoepidermoid carcinoma, all of which assign either points or histologic characters that will define a low and intermediate or a high grade tumor. I will change this star here that says not bad for the AFIP system to actually, this tends to undergrade. The Brandwein system tends to overgrade, and then these others end up somewhere in the middle. What our group has found that it's probably, again, doesn't matter to you guys, but if you ever have a grading dilemma and uncertainty how to treat the patient with your patients with mucoep, what I recommend is just talking to your pathologist about what grading system they're using. We've ended up starting to use the Brandwein point-based system, which may assign more tumors into the intermediate grade group as opposed to the low grade group. However, if you get an intermediate grade in a brand wine, these actually behave biologically like the low grade. If you have a high grade in a brand wine, these are the ones that are actually biologically more at risk for behaving like a high grade tumor. So some papers out there, including the ones from this institution, think that a brand wine high grade is truly a high grade, and a brand wine low and intermediate grade can probably be treated like a low grade tumor. So if there's ever a question, just ask what grading system is being used, and that would be my recommendation from a treatment perspective. I don't know, what do you guys do?
And then Nicole, just if I can chime in.
Yeah.
What you as radiologists need to remember is, just like she's going through all these grading systems histologically, we need to radiologically guide some kind of management. And when you have low grade mucoepidermoids, they're going to look like low grade tumors, or they're going to be well differentiated. They're going to have, because they have a high proportion of the mucinous cells, there's going to be prominent cyst formation on imaging. Whereas high grade, it's going to be, if it's poorly differentiated, what do we see? Well, we see more solid components. We see irregular margins. It starts to look like a bad cancer, right? So when you're describing that, it matters, like, because then our radiologic features are used, you know, the radiology and pathology correlate is so critical, because we can screw ourselves up if that makes sense.
Yeah.
We can guide the wrong pathway by our words as well.
Right, for sure.
I just say that for us, we actually don't use any of the systems because they're confusing and there's overlap, and I don't think people actually know them particularly well. So we essentially use everything's low grade except if it's high grade, and meaning that if the tumor is particularly cystic, it tends to be low grade, and we essentially only use the cystic component of it as our main main rule of thumb for kind of going in the direction of low grade. And then if it has mixed solid and cystic, as you'd see radiologically, again, that sort of moves toward the intermediate grade, but at the same time still typically is biologically low grade. So we still favor calling those for the most part low grade. And we very rarely make intermediate grade. If we write intermediate grade, it gets accompanied by a note. And it talks about the fact that there are mixed features, and the fact that there are mixed features means that it may be biologically more aggressive, but kind of stop there. And the high grade ones, typically we actually have to identify high grade ones by the molecular, looking for MAML2 translocation in them, because oftentimes they really just look like a high grade carcinoma. They have a very small cystic component, and sometimes it's actually difficult to even know that they're mucoep. So it's usually mucoep versus other when they're high grade. And at that point in time, we actually really rely on the molecular change of a MAML2 to say it's a high grade mucoep. So it's typically all low grade or intermediate grade, which, as Nicole mentioned, would sort of favor the sort of low grade behavior. When it's high grade, it really looks high grade. Same as you'd see radiologically, it would be infiltrative and a little bit ugly. And the way of being able to tell it's a high grade mucoep would be the genetics.
That's very, very, very good point. We've in fact identified, as you said, like, oh, this is a high grade carcinoma. Oops, it has MAML2, it's mucoep. Exactly. Cool. Oh yeah, so here are the charts again, just of the low, intermediate, and high grade, as you can see, kind of supporting the theory that we're discussing. Cool. So adenoid cystic is our second most common malignancy that, as you all know, well, very, very frequently presents with perineural invasion, and these patients have nerve pain. So an adenoid cystic without nerve pain is certainly possible, but very, very common. And so the genetics here are of the MIB-NFIB family rearrangements, and the morphology is very, very characteristically these sort of tubular or cribiform or solid. Cribiform here meaning sieve-like, or some people like to think of it as sort of Swiss cheese, but really it's these sort of stromal bluish mucinous areas surrounded by these epithelial and myoepithelial cells. Here's an example of the tumor sort of hugging the nerve, right, in a form of perineural invasion. And for us, we look at the amount of tubules, the amount of these cribiform or sieve-like structures, and the amount of solid growth in order to help determine potential grades. So, it's thought that the more solid it is, the worse, and the more sort of tubular and cribiform it is, the lower. We can use assistance with immunohistochemistry to determine the two cell types. In this case, these epithelial cells versus the myoepithelial cells. The myoepithelial cells here on the right are staining with our nuclear marker P63, and the keeps happening with my earring. It keeps getting caught. There it is. Yeah, help. And the epithelial cells here sort of sandwiched between these negative or blue myoepithelial cells. So this pattern can be very helpful. If we are uncertain the number of cell types, this pattern can be very helpful in determining the two cell types of epithelial and myoepithelial, or, quote unquote, basal type cells, and determining adenoid cystic. So, once you have your tubular, your cribiform, your solid, your diagnosis, you also then have to look out for additional poor transformations, such as dedifferentiation or high-grade transformation, which is a even worse high-grade component arising in an adenoid cystic of any tubular, cribiform, or solid morphology. And so what that looks like is essentially solid adenoid cystic here on the left, which has some vague, stromal bluish mucin seen here, but really is mostly solid. But the nuclei are very kind of dark and round and wrinkled. However, dedifferentiation or high-grade transformation is an increase in the nuclear size, in the characteristics of the chromatin, and mitotic activity, necrosis, et cetera. So we are always aware that pretty much any salivary type of carcinoma can present as this really bad high-grade carcinoma, like Peter was saying. And sometimes you find it very hard to distinguish what actual subtype of carcinoma it is, but what matters most is that it's high grade, and how you might be able to identify the subtype of carcinoma is by either finding a lower grade area in conjunction with it, or by identifying the appropriate genetics relevant to that particular tumor. One of the histologic mimics of adenoid cystic for us pathologists is polymorphous adenocarcinoma. This is formerly PLGA, or polymorphous low-grade adenocarcinoma, but the low grade was removed from the name because, again, these could also be high grade. So we now call them polymorphous adenomas, and we make a comment as to whether they are low or high grade. Unlike adenoid cystic, they have a single cell type. However, architecturally, they can mimic adenoid cystic with tubules and cribiform growth, even perineural invasion. Interestingly, here it is. Here's polymorphous adenocarcinoma with an infiltrative growth pattern, perineural invasion, but different appearing nuclear morphology and different genetics as well. One of the interesting findings for us for polymorphous adenocarcinomas is they lack the second myoepithelial or basal cell type. P63 and P40 function similarly, but specifically in polymorphous adenoma, they do not express the P40 positive myoepithelial or basal cells. So this can be a very helpful marker to be negative when we have a small biopsy and we are not sure whether it's polymorphous or adenoid cystic, or for that matter, even a pleomorphic adenoma, which also has two cell types. Okay, so there's another variant of polymorphous adenocarcinoma that is sometimes called cribiform adenocarcinoma. It tends to have similar kind of vesicular, almost papillary thyroid carcinoma-like nuclei, but with some solid growth and various papillary architectures. These are, I didn't write it down here, but both cribiform and polymorphous are related to, let me see if I can write in here, where's my, hold on. Nope. Okay, hold on 1 second. I really want to annotate. Will it let me annotate? No. This is not letting me annotate. Very weird. I'm over it. All right. I hate when Zoom doesn't do what I want. Okay, PRKD gene. So both polymorphous and cribiform are related to PRKD gene mutation or rearrangement. So that can be very helpful diagnostically in these cases as well. Okay. I guess the one thing clinically I should mention is that the tumors that are labeled as cribiform that occur outside of the standard polymorphous location, which is the palate, right? So generally polymorphous arises in the palate. Generally, this so-called cribiform variant arises outside of the palate. This variant is thought to have more frequent nodal metastases than the conventional polymorphous type. Just interestingly, so this may be a slight biologic divergence between these two morphologically and genetically similar tumors. So I think that's interesting. All right. Acinic. So acinic cell carcinoma is a tumor that resembles the serous acinar cells of the parotid gland, but it essentially grows in solid sheets without any intervening ducts or adipose stroma. These are generally low grade, but again, can also have a high grade or dedifferentiated variant. This is a little bit outdated. We do have some known genetics for acinic cell carcinomas that have been described recently. Again, I'm happy to send that along if you'd like. But essentially, acinic cell shows these sheets of serous acinar cells that still retain the pre-digestive zymogen granules that we can see as these purple granules. The high grade or dedifferentiated type of adenoid cystic, acinic cell shows here we have more of the lower grade component on the right, where you still can maintain these ductal or acinar-like structures. But then on the left, it turns into these solid sheets with mitoses and potentially necrosis. So again, a very shift from a lower grade to a higher grade, certainly with worse prognosis and behavior. Okay. Secretory carcinoma, formerly known as mammary analog, now just secretory carcinoma, secretory carcinoma, was described due to its resemblance to the identical type of carcinoma in the breast, generally occurred in kids or juvenile, younger patients, teens, that had this ETV6 and TRK3 fusion. And so this was discovered histologically and genetically identical in the salivary gland. It is composed of papillae, cysts, ducts, these sort of microcysts full of this milky secretion. These are characteristically staining for our S100 and mammoglobin protein. So if you see these reported, generally mammoglobin there is a probe for this type of carcinoma. It again, like many, is generally low grade, but can have a high grade transformation as seen here from this shift on the left. You see this more circumscribed area, and then boom, on the right, you have this more solid pattern with invasion and a encroachment of this was like a buccal mass. So you have the buccal mucosa here, the skin here, right? And the salivary duct here. So you have dense infiltration of surrounding tissue, you have necrosis, mitoses, perineural invasion, et cetera. These are things that are going to predict high grade behavior. So morphology, immunoprofile, and genetics can all help in diagnosis of secretory or secretory carcinoma. On the other hand, salivary duct, I put these two together because they both kind of resemble known carcinomas of the breast. Salivary duct carcinoma tends to resemble high-grade DCIS of breast / apocrine types of carcinoma of the breast. But essentially, most salivary ducts are by default infiltrative and high-grade. This is the vast majority of them. I'll show you what the morphology looks like, but it is important to note that they often are positive for androgen receptor, and most of them have HER2 amplification. So these are potential targeted treatments, right? So androgen blockade and Herceptin can be used in these patients. I will note that all salivary gland tumors, including salivary duct, should essentially be negative or extremely weak and junky for estrogen and progesterone receptor. If we see any significant ER/PR positivity in a tumor lying within the salivary gland, I would argue that that is likely to be a metastasis from a breast site rather than a true salivary primary. So in this case, the salivary duct has these large nests with central necrosis, with again some punched out or cribiform types of spaces, but very nice nuclear expression of androgen receptor and membranous expression of HER2. So commonly seen in salivary duct, but again, this apocrine morphology that resembles a breast type of carcinoma. So there are these other rare types of carcinomas, these intraductal carcinomas that, unlike the others that we've seen, are bounded by a benign peripheral myoepithelial cell layer. And these are essentially considered intraductal, non-invasive carcinomas in this stage. They can invade, and once they do, of course, it should be noted, but because they reside within the duct, they're essentially in situ and generally behave pretty well. Epithelial myoepithelial carcinoma is another rare one that tends to be composed of a combination of epithelial and myoepithelial cells, and again in these lobules with central necrosis, but sheets of clear myoepithelial cells punctuated by these ducts. This can be a challenging diagnosis to make. It's a rare diagnosis, but generally pathologists should be aware of the common features of a high-grade type of cancer, if present, like necrosis, mitoses, perineural and vascular invasion. But the specific epithelial myoepithelial diagnosis may arise if it meets these other morphologic criteria. The other interesting one is this so-called clear cell carcinoma of salivary type. So these clear cell carcinomas of salivary type can arise either in salivary gland locations or in fact within the jaws, within the maxilla or mandible. And in this case, they are referred to in the literature as odontogenic clear cell carcinomas as opposed to salivary clear cell carcinomas. But what's interesting is that whether they occur in the salivary gland or in the mandible / jaws, the morphology and the genetics is identical. So they're essentially these sheets of cells with extremely clear or pale eosinophilic cytoplasm, these wrinkled nuclei, these bands of pink hyalinized stromal material kind of coursing between the nests. They almost stain identically to a squamous cell carcinoma, but they have a very specific genetic rearrangement of EWSR ATF1, and this rearrangement is present both, again, in the odontogenic and in the salivary locations. So another tumor to be mindful of, that's a rare variant, but interesting and can be genetically sorted. Sometimes then in the salivary gland, we get carcinomas that can look like nasopharyngeal carcinoma. Sometimes they are metastases from nasopharynx. Sometimes they are primary or thought to be primary in the salivary glands and potentially associated with Epstein-Barr virus, just like that of the nasopharynx. But here we have these sort of syncytial sheets of cells with a primitive squamoid morphology, potentially with Epstein-Barr virus. I don't think I have noted here, but I will mention verbally that, even though these nasopharyngeal or type of carcinomas may be regarded as non-keratinizing squamous cell carcinomas, if we see non-keratinizing squamous cell carcinomas in the salivary gland, we want to think about either relationship with Epstein-Barr virus or relationship with HPV, right, coming out of the base of tongue or tonsil. Very, 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 very rarely we may see metastatic HPV base of tongue oropharyngeal carcinomas to level 1 or low level 2, and it may resemble a salivary gland primary, right? But the presence of virus should always be evaluated in these non-keratinizing lesions and should potentially direct one to a search in the nasopharynx if EBV and the oropharynx if HPV. So just a rare type of thing that we may encounter. The last thing is if it's a keratinizing carcinoma, right? So not a non-keratinizing, but a keratinizing carcinoma of the salivary gland, we may want to consider a metastasis from a cutaneous site, mostly the scalp to the parotid, because keratinizing squamous cell carcinomas of the parotid generally are not primary. Generally, they are mets. Interestingly, you can determine that they are metastases. I don't have that slide here, but you can determine that they are metastases by proving that they have the ultraviolet mutational signature of cutaneous carcinoma. So usually it's the C to T or the CC to TT transition in many genes. Our panel here looks for that, our standard, OncoPlus panel, and our molecular pathologists do report whether tumors have a UV mutational signature, and that can be very helpful in determining whether they're cutaneous metastases. So that's all I have for now. Do you guys have comments or questions?
That was an excellent review. Thank you so much. I really enjoyed it.
Oh, you're welcome. I can send out the recording, and I can actually, if you guys are interested, also send up, I think I have an updated presentation with the updated genetics and stuff. I'm happy to send that out if you guys would like.
That'd be great.
Sure. All right.